Friday.
Yeah, exactly.
Friday.
Okay, and we are live. Hello, web shadowers. Thank you all for joining our session this afternoon. Today, we have the pleasure of once again hosting Dr. Janiczek, who will be teaching us about anesthesiology. As always, please remember the Google form will be posted in the chat box and in the description of this video at the very end of the session, and you'll have 30 minutes to fill that out. With that being said, Dr. Janiczek, you can start whenever you're ready.
Awesome. Thank you guys so much. And thank you for having me again. Today, I'm going to talk about anesthesia. So if you missed my presentation about anesthesia back in September, this will be a good refresher. If you were able to make my session in September, I did expand a little bit and added a couple more cases. So hopefully you guys will get a little bit different flavor of anesthesia from this presentation. So first, a little bit about me. I was born and raised in Iowa. I attended the University of Iowa for undergrad and med school there at the Carver College of Medicine. I'm currently a fourth-year resident in the Department of Anesthesia at University of Illinois, Chicago. And then I'll be going on to a fellowship at the Ochsner Medical Center in New Orleans to do cardiac anesthesia. So this is a little outline of what we're going to talk about today. A little bit of insight into why I chose anesthesia, because I think that's always helpful when you guys are trying to figure out what specialty you maybe are interested in, down the line. Then I'll talk about what is anesthesia, and beyond just general anesthesia, which I talked about last time. We're going to talk about two additional types of or areas of anesthesia that we can practice in: neuraxial anesthesia and then also pain management. And then if we have time at the end, I'll talk a little bit about the path to becoming an anesthesiologist and also a hot button topic, and those are certified registered nurse anesthetists or CRNAs. So let's get started. So why did I choose anesthesia? So first of all, I had this innate fascination with the interaction between human physiology and pharmacology, and especially on the acute time frame. So, all doctors need to know physiology and pharmacology. However, in anesthesia, it's a very acute setting. We see low blood pressure, and we can treat it right away with medicines in the operating room, and then see the response on our monitors. So it's a very, short time frame. We get to see, the fruits of our labors and everything like that. I also had a love for the operating room environment. I know some people really love the operating room, some people hate the operating room. So it really just depends on how you feel about it. But for me, it was an instant, kind of love for that, fast-paced, high acuity environment. Third, ability to do procedures. So, in our average day, we do a lot of procedures, from intubating patients to placing IVs, placing central lines. We can do epidurals if we're on the OB floor. Just really, good opportunities to use your hands, and that was something that I was looking for as well. We are able to work with different specialties on a daily basis. So, one day I may be in the cardiac operating rooms, the next day I may be in the OB floor, the next day I may be, working with orthopedics. So we need to know a little bit about every single specialty in order to provide care for those patients. But at the same time, we don't need to dive into the nitty gritty of each of those specialties as much as you would if you were in that specialty itself. And then I kind of touched on this a little bit already, but the interventions that I want to do as a physician can have an immediate impact on the patient. And so bringing back the blood pressure idea, low blood pressure, I treat it, I see the response, and that's something that's, I guess, gratifying to me, if you will. But it's something that I never wanted to be the type of doctor that, told a patient to, take this pill and come back and see me in 3 months. And then the last one could be a little bit, splayed in terms of positive or negative. Basically, there's very little continuity of care in anesthesia. We don't see the same patient twice very often. Every now and then we do. And so, it provides a little bit of variety. And, we're not seeing the same, kind of frequent flyers, if you will, that are always coming back for, blood pressure issues or diabetes issues or anything like that. The downside to that is if you do want to have a long-lasting relationship with your patients, then anesthesia is probably not the best field, just because you won't really be able to see, them longitudinally or, in the chronic setting. All right, so let's move on to, what is anesthesia? And so first off, we're going to talk about general anesthesia. This is typically what you think about when you think of surgery and anesthesia. And so let's dive into it. So general anesthesia is made up of 4 pillars: analgesia, which is pain relief; paralysis, which is also termed muscle relaxation; amnesia, which is the loss of memory. So we try to, have, the patients not really remember the operating room to the best of our abilities. It's not always a great place for patients to, if they're scared, they're, obviously nervous about what's, the surgery that's going to happen. So, we can give them medicine to help with, some of the amnesia, and they won't really remember the surgery at all. And then lastly, unconsciousness. So you can see on the bottom of this slide, there's a spectrum basically from the awake state to the asleep state, with the middle being the sedated state. And so on the awake side, we have what's called local anesthesia. If you've ever been to a dentist and they've, injected your mouth with some lidocaine or Novocaine for a procedure, then, that's local anesthesia. We can use that too for small procedures, where we don't need to put a patient asleep, and we don't need to use regional anesthesia or anything like that. Neuraxial anesthesia I'll discuss in a moment. And then regional anesthesia is basically where we can numb up specific parts of the body based on what nerve supplies that area. So for instance, if you're having shoulder surgery, we can basically numb up your shoulder for the surgery, and you can have really good pain control from that. It's called a nerve block. In the middle, in the sedated state, we have sedation, or also termed monitored anesthesia care, or MAC, M-A-C. So basically what that means is we don't put the patient under general anesthesia. So typically we don't need to place a breathing tube in the patient or anything like that. These are for minor procedures, that are typically pretty short, and they're not as invasive as some of the other surgeries we do. So they can be, very well tolerated with just some sedation. And then lastly, we have the asleep state, and that's the general anesthesia state. So what that is that's what you typically think about when you think of surgery and anesthesia in general. And so that's where you're basically given enough medicines to make you extremely, in a deep state of sleep. And that's when we need to place a breathing tube, because otherwise you won't be breathing. We give you so much medicine that you're not breathing on your own, basically. So there's 3 phases of anesthesia. So induction of anesthesia is often likened to a plane taking off. And so there's a lot of parallels between anesthesia and the airline industry. And so this is a really easy way to remember, kind of these 3 phases. So induction, this is when you're getting the patient off of sleep. And, it's a very tenuous time. A lot of things can happen during this time. And so, everything, in the operating room tends to stand still at this point. And, it's really focused on getting the patient asleep, getting the breathing tube in, everything like that. The next phase is the maintenance phase. This is, kind of like autopilot. If you were flying a plane, you're at your cruising altitude, everything's settled. You got the breathing tube in, the surgery started, and the ventilator is breathing for the patient. You're giving them medicine through the breathing tube. That's keeping them asleep, or you could give it through their IV as well. And you're basically just monitoring the patient for any changes in their vital status or vital signs or anything like that. And then lastly, emergence is like landing a plane. And so once again, landing a plane is a very tenuous time. It takes a lot of concentration, a lot of focus. Same thing with, waking a patient up from surgery. And so the other thing about, waking a patient up is it's not instant. It does take some time, just like landing a plane. It's not something that just falls out of the sky, and so you're able to, you need to be able to plan this out typically and be able to, time out when the surgery will be done and then wake the patient up appropriately. So the first case I want to talk about is a case about general anesthesia. So we have a 19-year-old male. He's 75 kilograms and his BMI is 24. He had, for 2 days now, he's had sharp abdominal pain in the right lower quadrant. He also endorses being nauseous and vomiting several times since the pain started. And now he has a fever today. Past medical history-wise, just some childhood asthma, but he no longer takes inhalers, hasn't had any issues with his asthma in years. We don't know his surgical history, his family history. His mother had some diabetes. His father was a little obese, had some high blood pressure and some high cholesterol. Social history for our gentleman, he doesn't drink alcohol, he smokes marijuana daily, and then no illicit drug use such as marijuana, cocaine, or heroin or anything like that. So what information do we want to know? Basically, besides confirming all that information that we read in the chart, we would want to ask, have you had any previous anesthesia? If so, any complications? Any family history or problems with anesthesia that we want to know about? Specifically, something called malignant hyperthermia. It's a condition that runs in families, and so there's extra precautions that we would want to take if the patient has a history of malignant hyperthermia. So we definitely want to ask that question. Any allergies to medicines? Obviously, we don't want to give a patient medicine that causes an allergic reaction. So we want to know that. Last PO intake. So basically, when was the last time they ate anything? And so the reason why we want to do that is to prevent aspiration pneumonia. During anesthesia, stomach contents can come up through the esophagus and then go back down into the trachea, into the windpipe. So we don't, especially when we're intubating the patient, that's a very common time, or extubating, or taking the breathing tube out. Those are kind of two times when it's, the contents can be aspirated. And then we do a quick review of systems, any chest pain, shortness of breath, abdominal pain, everything like that, we would cover as well. All right, so now we go on to examine the patient. So the number one thing for anesthesiologists to examine is the airway. We are obsessed with it. It is what keeps us up at night. And so this is it's called the Mallampati classification. So basically, 1 to 4 is the classification. Class 1 is the best, class 4 is the worst. And as you can see, basically we have the patient sitting up, and they basically open their mouth, and we look inside. And so if we can see basically all this open space, these are actually the tonsillar pillars back here. So these are their tonsils. This is the uvula back here. We can see most of their palate, all this tongue is down, a little bit lower in the view. So this is a really nice view. And then you compare that to, class 4, where, the tongue takes up most of this image. You can't see the uvula anymore. You can't see the tonsillar pillars anymore. You really just see part of the palate back here. And so class 4 is associated with more difficult airways. And so, this would definitely alarm us to, maybe the breathing tube will be slightly more difficult to get into the patient, everything like that. Class 2 and class 3 are basically in between these two extremes. And so as you can see, as you go from 2 to 3, it gets a little bit worse. 2 is more like class 1, class 3 is more like class 4. And so, these are, sometimes hard to determine exactly. And so, you may call them just a 3 because it's, it'll make you a little bit more prepared, and maybe have some extra equipment in the room. But then, class 2, if it looks like this, it's pretty safe to say it's, it may be an easier airway. So luckily, our patient has a class 1 airway. That's typically found in the young, healthy, skinny individuals as well, which our patient basically fits those characteristics. So some other things we look at when we examine the patient. So one thing is called the thyromental distance, or TMD. So basically this picture on the right shows you, basically it's the tip of the chin, or the mentum, to the tip of the thyroid cartilage. And so as you can see, this can be measured in a distance. The shorter the distance, the more problems we may have when we're intubating the patient. The airway may be more anterior, we call it. And so it does alert us to maybe do a video laryngoscopy, which I'll get to in a minute, or maybe even a fiber optic intubation. And then mouth opening. So we basically look at how far can the patient open their mouth. Do they have, a mass that's, preventing them from opening their mouth? Is there some other pathology that prevents them from opening their mouth? And so we want to know that as well. So other things we look at, basic things, cardiac exam, what's their heart rate? What's their, the rhythm of their heart? Are there any murmurs? Those are all important to note before the surgery. Respiratory wise, lung sounds. So does the patient have asthma and, they're wheezing terribly? Do they sound like they have pneumonia? Anything like that, we definitely want to know ahead of time. And then lastly, IV access. So we want to know, does this patient have a reliable IV? Can we give them medicines reliably? or are we going to have to find another IV? And so sometimes the patients come from the emergency room with a great IV. Other times they come with a terrible one, and we have to place a new one. That's something we always look at. So, all right. So moving on. So basically, how do we intubate patients? I put several different ways that we can on here. So the basic way is called direct laryngoscopy, which I'll show you on the next slide. But this is a laryngoscope right here. This is a battery pack basically, and then this is we call it the blade. It's not actually sharp in any way. Basically, what we do is we use it to move the tongue out of the way so that we can see the vocal cords and the glottic structures. There's also, so these, you can kind of see this curve to the blade here. These blades over here also have a curve. Those are called Macintosh blades. If you have a straight blade like these are called Miller blades. Honestly, it's just a, more of a choice, which one you're more comfortable with. Most of the time, both work. Some places you will train as a resident, you'll use more Mac blades. Some places you'll train more Miller blades. Up in this top left corner is a really good example of video laryngoscopy, which I mentioned before. So basically, this is called a glide scope. That's just the brand name of it. But basically, what it has is it has a camera at the end here, and so it shoots an image of what it sees beyond the camera. And so this is the glottic structures that that I was talking about before. So you can see the vocal cords here. These are some arytenoid cartilage or cartilages, and so we would place the breathing tube right in there. In the top right corner, this is called a McGrath device. So basically, this is the same idea as the video laryngoscope. There's a little video camera right here. And the only difference is that you only get this really small screen. So it's really portable. It's really good to take to the intensive care unit to intubate someone if you need to in an emergency, something like that. But it only shows up on this little screen, where this has a much bigger screen to it. Down here in the bottom right corner, this is a fiber optic intubation. So basically, you can see this provider using this kind of long spaghetti string type thing. Basically, what it has is it's a camera at the end here. And what it allows you to do is, you can't really see the image, but there's an image up here, and it allows you to really guide through the mouth, and you can do it through the nose as well. But for patients who can't open their mouth very wide, we won't even be able to get one of these blades in there. We can then use a device like this to kind of snake the breathing tube in past any obstructions or anything like that. These are just some of the ways that we can intubate patients. These images basically show direct laryngoscopy. So you can see this anesthesia provider is using a laryngoscope right here. She's got he or she has the breathing tube right here, and they're basically just looking inside the mouth directly. And so as you can see from this image on the right, the esophagus is right next to the trachea here. So a common thing for new anesthesia providers to do is actually inadvertently place the breathing tube in the esophagus, which is not something that we want to do. And so it has to be quickly recognized and basically taken out and replaced into the trachea. Obviously, the esophagus will, or if we try to ventilate the patient through the breathing tube in the esophagus, it'll basically just blow up the stomach, and it won't help us at all. And in fact, it'll increase our chances of aspiration and everything like that. So it's something that needs to be recognized very quickly and then replaced into the right spot. So here's basically a view, several different views of how we grade where, once we're looking inside the mouth, what we see. Okay, so this is called the Cormack-Lehane grade. So it goes from 1 to 4 once again. So as you can see, grade 1 is really nice. You can see all the vocal cords, all the glottic structures. The epiglottis is nice and out of the way. You can see exactly where you need to place the breathing tube. And this is considered, the best view, you can get. Grade 2, you can see the epiglottis is starting to flop down kind of in the way of your view. You can still see the bottom of the vocal cords right here. And by this diagram, you can see, you usually see a little bit of the glottic opening. versus grades 3 and 4, you really don't see any of those structures. Grade 4 is the worst. So basically, you only see the tongue. So that's that little structure, that bumpy structure right here. That's the tongue, and so you can't see any of the glottic structures like over here. So you either need to find a different view, or use a different tool, or position the patient's head and neck in a different way that will help you see things. But this is not a very easy, intubation to make. This one is sometimes doable in the right, skilled hands. You can, use what's called a bougie, or basically this little rubber tool that we have that can snake underneath the epiglottis, and you can find your way into the trachea. It's not, something that you want to do, but if you need to do, you can. So luckily, once again, our patient has a grade 1 view using this grading scale. All right, so the patient's intubated. Now what do we do? And so it's not time to check our stocks. It's not time to play Sudoku like many people think anesthesiologists do. There's a lot of stuff we do after the patient's intubated. So if there's any additional monitors that we need to place, any IVs we need to place, arterial lines, which are specialized IVs that help with blood pressure measurement, all those things can go in after the patient's intubated. If we need to change the patient positioning at all, we can do that. We basically begin monitoring all their vital signs and everything like that right away. And then that continues until the surgeon is done with their operation, or if they're wrapping up, and then it's time to wake the patient up. So basically we do that by turning off our inhaled anesthetic that's going through the breathing tube. And then, if we did paralyze the patient or use neuromuscular relaxation for the surgery, which is not required for every surgery. There's kind of a specific list. Then we can use other medicines to reverse that blockade and get them nice and strong again, so that they can breathe on their own once we take the breathing tube out. And then lastly, once we're ready to extubate the patient, we can do that, and then we take them to the post-anesthesia care unit. So I think that wraps up. Yeah, so that wraps up the general anesthesia outline. So let's move on to the neuraxial anesthesia component, and we'll learn about that. So what is neuraxial anesthesia? So basically, there's a couple different sub names for it, I guess. So spinal anesthesia, epidural anesthesia, or you can do what's called a combined spinal epidural. So spinal anesthetic is basically where we inject local anesthetics. Typically, it's a mixture of bupivacaine, which is like a cousin of lidocaine, and then also an opioid medicine. So typically fentanyl into what's called the intrathecal space, which I'll show you in a minute on a diagram. Some advantages: it's quick onset, and it provides great pain control for a variety of surgeries. So you could do it for cesarean section if you're having, a pregnant individual that you're taking care of. You can do it for knee replacements in the right setting if the surgeon is quick, because it'll basically numb up everything from, essentially the belly button downwards. And so you can use it for those, orthopedic procedures as well. Moving on to an epidural. So basically, this is a local anesthetic plus or minus an opioid injected into the epidural space, which once again, I will show you in a minute on a diagram. And then lastly, a combined spinal epidural is a procedure we do often on OB, where we also, we basically do a spinal and an epidural at the same time. And so there's some advantages to that, but there's also some disadvantages, which I'll get to in a minute. So here is the diagram I was talking about. So this is basically, it's called a sagittal view. So basically, if you were looking at someone sideways, this is their spine, cut away. And so each, vertebrae is here with, the discs in between. This is their spinal canal. And so the spinal cord itself actually ends at the upper lumbar vertebrae. So you can see the thoracic spine ends about here, then it's the lumbar spine, and then the sacrum. So, typically we do, our neuraxial anesthesia for, specifically for labor, kind of in the lower lumbar or mid lumbar region. So, L4, L5, sometimes L3, L4. And so basically what it means is, you can see these two different needles. We don't typically do this at two different levels like this. This is more for, just showing the diagram purposes. Basically, the spinal is, you actually break through the dura. the dura mater. So this is the dura mater running around, and you basically get into the intrathecal space. And so your goal is to actually get cerebral. This is full of cerebral spinal fluid as a continuation from the brain and everything, and the spinal cord itself as well. So basically, you want to get into the intrathecal space, and then the CSF will actually, start dripping out of the spinal needle. And so before it starts dripping too much, you attach your syringe of medicine and inject your medicine into this intrathecal space. And basically what it does is it allows you to, numb up these nerves, and these nerves are all supplying, the lower extremities and such. So the patient won't really feel anything below this point. Moving on to epidural anesthesia. So basically, this is where we don't go quite as far into the dura mater. And so we, basically try to find the epidural space. So it's a potential space, meaning that it's not actually something that's there all the time. It's basically right outside the epidural layer of the meninges. And so I'll show you on the next slide kind of how we find that space. But basically, we can, inject medicine typically through a catheter that we leave behind. And so if you're on the OB floor, we typically leave an epidural catheter in. And so basically we put in it, once we find the epidural space, we find, or we insert the catheter and then we hook it up to a pump that will give the patient medicine, throughout the duration of labor. And so let's move on to the case, and I'll talk about that in a little bit. So our case is a 32-year-old G1 P0 female at 39 and 5 weeks, presenting in labor. So basically the G1 P0, if you guys have seen any OB-GYN shadowing, you probably know this lady is pregnant for the first time, or it's her first gestation, and then she hasn't actually delivered any children yet. That's the P0 part. So she is having contractions every 4 minutes, and her pain is a 9 out of 10 in severity during the contractions. Her last cervical exam showed she's dilated to 5 centimeters, and the baby is at a -2 station. So, she's starting to dilate, and then, the baby's starting to kind of descend a bit, not too much yet. And so basically, what can we offer her for pain control? We could theoretically do a spinal. It's probably not going to help us very much. We could do an epidural, or we could do a combined spinal epidural. And so basically, depending on your practice and your hospital, that's how you would, choose, the spinal the combined spinal epidural or the epidural. And that's kind of a discussion outside the scope of this talk. But basically, you could do, either one, and have success. So why not a spinal? The reason why is, this technique is really kind of a one-time, injection that you do into the intrathecal space, and you typically don't repeat it. And so you can expect maybe 90 to 180 minutes of pain relief from this type of injection. But there's no way in this situation that you're going to know that the patient's going to recover, the patient could deliver in the next 90 to 180 minutes. So what happens if you give her the spinal, she may feel great, but she may not have long-lasting pain control that she needs for labor. So and then going on to the epidural versus CSE, like I said, it's a kind of outside the scope, but basically epidural only has a slower onset of pain control because you need to kind of titrate the medicines a little bit more. A CSE is quicker because you do that spinal dose, but you also leave a catheter behind in the epidural space. So you're still giving them medicine. And basically by the time the spinal wears off, the epidural medicine will have kicked in. And so you should have good pain control with both. Some risks with the CSE, you can have a little bit more hypotension or low blood pressure. You can have something called a post-dural puncture headache, and so that's basically where the CSF from the intrathecal space kind of comes back out the hole that you punctured in the dura, and that leakage of the CSF can actually cause a headache a couple days after the epidural. It can happen after an epidural, a straight epidural as well. However, it's a little bit more common when you do the CSE. So now onto the epidural technique, and so there's two kind of broad classes of or ways to do the epidural. So the first way is the loss of resistance technique, which is shown in the top 3 diagrams. So basically what you have is you have a glass syringe attached to a what's called a 2E needle. And so this is once again the cutaway view of the spine. So you go in between two of the spinous processes. Typically, for labor, it would be in the lower back or the lumbar spine. And you basically advance. These are ligaments, actually. So there's a ligament here that you have to get through, and then there's multiple ligaments, or fibers of the ligament here. And then you get to a point where you basically are touching the ligamentum flavum, it's called. So that's that last kind of ligament here before the epidural space. And so at this point, you can see that this syringe is filled with fluid and then a little bit of air right here. And then, as you're advancing through the ligaments, you're tapping on the syringe. And so basically what happens is, it's resistance, and then once you pop through the ligamentum flavum, then, you can see you can depress the plunger here, and it's called loss of resistance because it's just very easy to push in. And so, this is just filled with, saline. And so, it's not going to really give any pain control or anything. So we actually have to, attach a separate syringe with the medicine that we're going to give. But basically that's the loss of resistance technique. There's another technique called the hanging drop technique, which is shown at the bottom of the screen. So basically what you do is you put a little bit of saline solution, so just salt water, into the hub of this needle, and then you advance through the ligaments, just like you do for the loss of resistance technique. And then once you pop through the ligamentum flavum and you get into the epidural space, it becomes a negative pressure system, and it basically sucks that solution into the needle, and that's how you know. So you basically will disappear off the kind of the hanging drop will disappear into the needle and into the space due to the pressure changes. So it's kind of, I've seen both techniques done. So it kind of depends on your preference level and which one you prefer. And so basically, after we do the epidural, like I said, the epidural catheter that we leave behind in the epidural space is hooked up to a pump that delivers medicine continuously, or you can set it up the pump to basically give a dose every hour. And so, a lot of hospitals will also allow the mother to give themselves doses through what's called a patient-controlled epidural anesthesia, or a PCEA pump. And so, the advantages to, this technique, sometimes the baby is delivered soon after the placement. Sometimes it takes hours, depending on the labor course. And so then, the epidural can be used also for a C-section as well. And so, you can use, the epidural if it's working properly, to go to a C-section as well. And so you wouldn't have to necessarily put the patient to sleep, which, provides extra risk to the mother and the baby as well. So we can troubleshoot the epidural in multiple ways. You may have to increase the rate of the medicine on the pump or give additional doses of medicine. You may have to reposition the epidural catheter, or you may have to replace the catheter altogether. Those are all pretty common things to do during the troubleshooting phase. All right, so let's move on to another field of anesthesia. This is our third one for today. So pain management. And so this has been really big in recent times. The past couple of years, it's really exploded in terms of number of providers that are going into pain management, and also the number of patients, seeking pain management. And so what is chronic pain management? So basically, it's a subspecialty within the world of anesthesia. And so it's pretty self-explanatory. These anesthesiologists focus on the chronic management of various pain conditions, such as low back pain or neuropathic pain. And so, some pain clinics are focused on interventional procedures, such as steroid injections or radiofrequency ablations, of nerves that are, maybe controlling or contributing to the pain. Other times they'll do nerve blocks for specific areas of the body as well. And then other pain clinics are more focused on pharmacologic interventions. So you can have non-opioids, such as, there's a lot of different non-opioids you can give a patient. You can also, give them opioids, but given the opioid epidemic, in this country, a lot of pain clinics have stopped giving, opioids specifically. So let's talk about a case about chronic pain. So a 43-year-old female is presenting with right foot and ankle pain for the last 2 months. So basically you talk to her and get some more history. You find out that she dropped a really heavy book on her foot. Basically, at the beginning of this time period, she was evaluated in the ER immediately after this event. And luckily there were no broken bones that they noticed on x-ray. They gave her some high dose ibuprofen and told to ice and elevate her foot until the swelling went down. So the patient listened to these, pieces of advice, took the ibuprofen, iced her foot. But basically 2 weeks later, the pain got much worse, and then the foot actually started to change color. It became even more swollen. And so she's been, sitting here for a month and a half with this, swollen foot, and finally coming to your pain clinic to get an alternative treatment. So this is what the patient comes in with. So you can obviously see the right foot is, much more swollen than the left. It's mottled in appearance, we call it. So basically it's a different color, look how red, and, it just looks angry. And then, this is, obviously the normal foot. And so it looks, much better. And, if this picture continued, you could probably see swelling up into the ankle and into the, the lower leg as well. So basically, what could possibly make a patient's foot look like this? And so there's a disease or disease process called complex regional pain syndrome, or CRPS. And so there's two types. It's type 1 and type 2. So type 1 is where there's really no clear cause, versus type 2, where there's some event that triggered the symptoms. So this is also called causalgia sometimes. There's some simple symptoms that come with CRPS. You can have excessive pain to even light touch to the affected extremity, changes in color or temperature to the affected area, swelling, changes in skin texture. So sometimes the skin becomes shiny, thin, hairless, everything like that. So how do you diagnose it? So there's no specific test that can diagnose CRPS. It's a combination of kind of the physical exam and history of symptoms. You could sometimes do bone scans to identify areas of excessive bone resorption near the site of injury, but those are not 100% reliable as well. Treatment, so a lot of times it's just watching and waiting. So some of them, or many of them will resolve on their own. You can do physical therapy, and there's some specific types of physical therapy you can do. It's one of them is called mirror therapy, a little bit outside the scope of this talk, but there's definitely other treatments. Spinal cord stimulators can be used. So basically that will just, you can place a spinal cord stimulator in terms of, basically sending signals to the nerves that are affected. And basically, you kind of just overload the system so they don't detect the pain from it, but instead it helps relieve the pain. Medications, ibuprofen, Tylenol, topicals, so lidocaine or fentanyl patches, non-opioid pain meds, gabapentin, all those sorts of things can help. But it's a debilitating condition, and I've seen a couple cases of it. It's quite stark when you do see it, but it's kind of an interesting diagnosis to make. All right, so I want to leave enough time for questions, but really quickly, the path to becoming an anesthesiologist. So 4 years of undergrad, 4 years of medical school, just like every other doctor. And then you go on to 4 years of residency. So the first year is the internship year. So you're rotating through general medicine, general surgery, emergency room, and then basically whatever else, whatever the rotations your residency program wants you to do before starting your second year of residency. So basically, PGY is postgraduate year. So how many years after medical school graduation are you? So, PGY 1 is the internship year, PGY 2 through 4. So basically, these are your clinical anesthesia years. They're also called CA years. So CA1, CA2, CA3. And so then once you get through that, you graduate from anesthesia residency, you can go on and get a great job, providing great anesthesia and be, fully functional, everything like that. You can, however, go on to do a 1-year fellowship if you want. So there's, many options for fellowships from anesthesia. So you can do cardiothoracic anesthesia, OB anesthesia, chronic pain management, regional anesthesia, so like nerve blocks for surgeries, and more a lot of orthopedic surgeries do nerve blocks, neuro anesthesia, and then pediatric anesthesia. You can even get into practice management, OR management, those kind of leadership style areas of medicine as well. And then I just want to quickly touch on certified registered nurse anesthetists, or CRNAs. And so basically, these are, providers in the anesthesia world that do 4 years of nursing school, typically 1+ years of critical care nursing, and then 2 or 3 years of CRNA school. It depends on each school. Some have a little bit longer training, some have a little shorter. The question that I always get asked is, are they a threat to the field of anesthesia? My answer is maybe. This debate has been around since I was a pre-med. I worked in a hospital as a pre-med, and the anesthesia residents were telling me about this debate. And basically my my thoughts on it are they have been around for a while. They will be around for a while. However, doing a fellowship can definitely separate yourself from the CRNAs and limit kind of your job loss to them. The other thing is you need to kind of learn to work with them as part of the greater anesthesia team, and this will be even a bigger concept in the future, going forward. So, are they going to go away? No, but can you work with them? Yes, and they're great people too. They just want to provide great great care to patients, and so they're a very valuable asset to the team. All right. So summary, so anesthesia is 97% chill, 3% complete chaos. Most of the time everything goes very smoothly. It's just, when things don't, it can be very, very difficult for a few moments. Some advantages, you can really carve out a niche that you enjoy, whether that's cardiac anesthesia, OB anesthesia, pain management. You can really, kind of dive into whatever you want. You don't need a fellowship to practice. Like I said, you can do a fellowship, but you don't need to. You get to work with a variety of different types of physicians and different providers. That provides a lot of variety during your day, makes it fun, everything like that. Some disadvantages, hours can be long, exhausting, stressful at times. There's not much continuity of care, and you get little to no recognition oftentimes. Patients don't really remember their anesthesiologist a whole lot. And so, it's more, they'll remember the surgeon, they'll remember, other people involved in their care, but they're, very rarely going to remember their anesthesiologist. So if you're okay with that, it's a great field. If you're looking for more of the recognition aspect, maybe it's not the best field. So, and then the practice, your practice can be heavily determined by the hospital or the surgery center that you work in. So, if you're working in a very heavy or, orthopedic hospital, obviously you're going to be doing a lot of orthopedic anesthesia, a lot of regional anesthesia, versus if you're working in a different type of hospital setting, you may, be able to, practice different types of anesthesia more regularly. So, all right. So this is all my contact information. You can email me with questions that you have. Go follow me on Instagram. It's at GetAdmittedMD. My online course is on Teachable. That'll teach you how to get accepted into medical school. I didn't really touch on this before. That's a boot camp I created after being on a medical school admissions committee for 2 years. And so I kind of packaged all the lessons I learned into that boot camp. So you can go check it out. You can always check out my website and then my YouTube channel as well. I would love to answer some questions. So I see the chat box. So I'll just kind of start going through these with the remaining time that we have. So the first question I see is, how often do you have to deal with adverse effects of anesthesia, either during or after it? It's not that often, to be honest. Most of the time it's maybe a little nausea, vomiting after surgery. And so, that's, maybe, a couple times a week you run into a patient that's, really nauseous or, vomiting after surgery. Most of the time we know about it ahead of time, especially if they have a history of nausea, vomiting after surgery, and we kind of take preventative measures to, help avoid that situation, because nobody wants to be nauseous and vomiting, after surgery. That's just not a great thing to have. So other than that, it's not that it's not that common. Other adverse effects, kind of range from minor to major. So, minor, maybe a little low blood pressure in the operating room. That's, daily. We face that all the time. We typically just treat that with, medicines and fluids and kind of get through it. Major adverse effects, heart attack, stroke, blood clots in the lungs, anything like that. Those are pretty rare. And so, you don't see those too often. Luckily, but they do happen. The next question is, what are the results of having a class 4 airway? Is that naturally occurring or does that happen because of the complication of disease? So both. So the first part, basically the results are really only, it makes it difficult for us to, place the breathing tube for surgery. However, in their everyday life, they may have, a little bit more snoring. They may have, some of the other symptoms that go along with, kind of just a congested airway. It can be naturally occurring, just everyone's anatomy is a little bit different. So my anatomy is different than all of your anatomies. It could be a complication of a disease process. So if someone has a big neck mass or, an oral cancer that's growing, obviously it's going to shift all the things in their mouth and throat structures. And so you can end up with a class 4 airway pretty quickly. Some people just, kind of naturally have it as well. So it really just depends. It can be both, naturally occurring as well as, a complication of disease. Is it common for patients who are intubated to have scratched vocal cords for a time post-intubation? So it's not, uncommon, I would say. Obviously we have to get the breathing tube in, we have to insert it through the vocal cords. Whether or not they're scratched or not, if it's a difficult intubation and, we're kind of having to get it in quickly, maybe it is a little bit more, severe of a scratch. However, one of the common side effects that we mentioned during, kind of the consent process for anesthesia is that you may wake up with hoarseness to your voice or a sore throat. And so those are from, placing the breathing tube through the vocal cords. You can get a little bit hoarse after surgery for a day or two. Typically it resolves on its own without many issues, but it does happen. How much more difficult or different is it to intubate children? Yeah, so there's actually a little bit difference. Intubating children can be quite difficult. So basically, if you remember the photos of the epiglottis and the glottic opening for an adult, so basically there are a few changes to the pediatric airway. And so basically the epiglottis is more what we call omega shaped. So it's a little bit longer and skinnier than an adult epiglottis. So that basically will cover up the vocal cords and glottic opening a little bit more. And so that's when we often will use a Miller blade. So if you remember the straight blade that I mentioned before, and what we do is we dig underneath the epiglottis and actually lift the epiglottis up instead of going into an area called the vallecula with the Mac blade. And that's how we lift it up in terms of using the different, two different blades. And so everything else is just smaller, obviously, in a kid. And so, it can be a little bit more challenging to intubate a child, but, it does happen and it's very common. And, that's why sometimes, anesthesiologists go to a pediatric fellowship to learn how to intubate, difficult children. And so the other thing with children that you often get is syndromes. So there's a lot of different syndromes that can affect the face structure and the mouth structure and everything like that, whether it's, cleft palate, cleft lip, all those sorts of things to, other genetic conditions that can lead to, large tongues, deformed airways, everything like that. So, most residency programs, you'll see, maybe one or two of those syndromic, or maybe up to 5, syndromic kids, but, places that have very busy pediatric hospitals, you may see a ton of those. So you may be very comfortable with, intubating those syndromic children. How would you recognize if an intubation tube has been placed in the esophagus? That's a fantastic question. And so basically, if you place the breathing tube in the trachea, one of the monitors that we have is called an end-tidal CO2 monitor. So basically what that means is it detects the end-tidal carbon dioxide coming out from the lungs. And so if you place the breathing tube in the esophagus, there's no gas exchange happening in the lungs. And so, the stomach is not going to produce the same carbon dioxide that, your lungs will. And so that's one way we know. There's some other, kind of quicker ways to know. So when you place a breathing tube in the trachea and you start, breathing for the patient, you'll see fogging on the breathing tube. That's just condensation from the heat of the tube is cold, but the patient's breath is hot. So you see condensation. And so if you don't see condensation, then that means there's really no gas exchange happening. So you're probably, in the esophagus and you're just inflating the stomach. You can actually look at the abdomen, and you can sometimes in patients, you can actually see their abdomen start to inflate. And so you can, you'll see the stomach start to, kind of rise, and then, you're inside the stomach. And then, probably the best one is you listen to the breath sounds. So, you can use your stethoscope, and, you basically put the stethoscope on the chest, listen to both sides. That's kind of our standard operating procedure after we intubate a patient, is just to make sure, even if everything else looks great, we should really listen to the breath sounds each time. And if you don't hear air movement in the lungs, it's probably a indication that you're in the esophagus and you're just inflating the stomach. So, all right. If a person comes in with an emergency tracheostomy, how would you work around that? So I guess my question would be, is the tracheostomy in place, or are they coming in to get the tracheostomy in place? I'll take the first one. And so basically, if they have a tracheostomy already in place, oftentimes we can just, it depends if it's a cuffed trach tube or an uncuffed trach tube. So basically, it's just two different types of trach tubes that they can use. If it is cuffed, then we can hook up our breathing circuit straight to the cuff in an emergency. If it's an uncuffed tube, then sometimes we take the trach out and actually put a separate tube into this, it's called the stoma, or basically the hole that's where the trach is. And it goes into the trachea, and then that provides our, oxygen, and we can put the anesthetic medicines through there. So it really just depends on the situation and, how emergent it is, or, if the tracheostomy tube is actually cuffed or not. So, let's see, what epidural technique do you do more often, or would it depend on the situation? So personally, at this hospital that I'm, at right now, we do more combined spinal epidurals, I would say. And so one advantage that I didn't mention is, by doing the spinal as part of the whole technique, you can actually confirm that you're in the right spot before injecting any medicine. And so that's kind of a nice, a nice confirmation. If you do a straight epidural and so you don't do the spinal part, you could get what's called a FOS, loss of resistance. So if you remember from that picture, once we pop through the ligamentum flavum, we get that loss of resistance. There's actually, in patients who are maybe a little bit bigger in size, or just their anatomy is a little bit different, you can actually get what's called a false loss of resistance. And so what that means is that it may feel like a loss of resistance, but it's actually not. And you inject the medicine, in subcutaneous tissue, or, in the wrong spot. And so by doing the combined spinal epidural, you have a little bit more of a confirmation test there. And so you're in the right spot by doing that. So I typically, I think in my practice, I'll probably do more combined spinal epidurals for my epidurals in the future. But obviously, if a patient has a history of, post-dural puncture headache, or, if I can't get the spinal, sometimes the spinal doesn't work, then, it's something where you just do the epidural itself. So are anesthesiologists the only doctors that provide epidurals? Yeah, for the most part. There's a little bit of an overlap, and so some other specialists do similar procedures, so like spinal taps and that sort of thing. So like neurology, so sometimes we'll do like spinal taps, to get CSF for testing purposes. Maybe they're working a patient up for some sort of spinal cord or brain disorder, and they need CSF, so they could do a spinal tap, but they don't do the epidural part like we do. So we're typically the only ones that do epidurals for patients. Is anesthesia dose dependent? Do you have to change how much is administered based on the patient's health and physiology? Yeah, for sure. And so, the classic example is the old, frail, elderly individual who maybe weighs, 50 kilograms, barely 100 pounds, soaking wet. Those patients aren't going to need as much anesthesia as, a young, healthy, college student who's on the football team. So we do have to, kind of change our plan and how much anesthesia we give a patient based on size, based on how much muscle mass they have, everything like that. If they're really, really sick, their heart's failing, their kidneys are failing, their liver's failing, we give them less anesthesia typically, versus a young, healthy, robust individual will need a lot more medicine to get through the surgery. when in medical school did you decide that you wanted to pursue anesthesia? Was there a specific moment? Yeah, so I actually knew back, before when I was an undergrad, I actually knew I wanted to do anesthesia. It was actually based on, I worked in the Department of Anesthesia as an undergrad as an anesthesia tech. So I was surrounded by anesthesia as the pre-med. I talked to the residents a lot, and I was studying integrated physiology in college. So I knew I loved physiology. I loved acute physiology and just learning all that, how the body works. And so, I kind of knew early on. I'm not saying that that's a good thing. A lot of, medical students don't know what they want to do until, the third year of medical school when, they're, about to apply to residency. So there's definitely perks and downsides to both. Obviously my path to anesthesia was very one focus, and, I kind of knew early on. The folks that don't know early on, that's actually sometimes a good thing, because then they can experience everything a little bit more and actually feel it out and see if they like it. And so there wasn't necessarily a specific moment, I would say, but like I said, it was during an undergrad, the undergrad years. So next question: what happens if intubation fails? Yeah, that's a great question too. So every so often, we get a patient who's very, very difficult to intubate. And so we have what's called a difficult airway algorithm as anesthesiologists. And so it's basically a set of steps that, if the patient, cannot be intubated, this is what we need to do. Ultimately, at the end of that is typically what's called a surgical airway. So it's a tracheostomy. And so either if the anesthesia provider is comfortable doing tracheostomy, there's something called a percutaneous tracheostomy, which use a kind of a kit, and then you can place a temporary airway that way. Or if your hospital has ENT surgeons or ear, nose, throat surgeons around, they can come in and place a real tracheostomy and be able to ventilate the patient that way. It very rarely gets to that point, luckily, and so we have so many tools as anesthesiologists now. Video laryngoscopy, fiber optic scopes that we can use to kind of get the breathing tube in multiple ways. But we do have an algorithm that, basically if the first attempt fails, this is what we do. And it's all centered on not doing the same thing over and over. So it's all, kind of focused on, what's the next thing that we try? And so then if that doesn't work, what's the next thing that we try? And so, the kind of terrible outcomes you read about and hear about from, anesthesiologists and airway fails, kind of come from doing the same thing over and over. And so that's when you kind of get into a bad spot. But all right, next question. As someone who has been on the admissions committee, what do you see as one thing well-rounded students miss that ultimately prevents them from getting into medical school? So that is a difficult question. So a lot of times it's clinical knowledge or not knowledge, clinical exposure, I would say. And so, shadowing or, working in a hospital is invaluable to kind of knowing what, doctors do and kind of, it's not all glamorous, to be honest. And, being a doctor has kind of this glamorous reputation, but it's really not. And so the students that, come into, the application to medical school and, think it's this great, great all the time field and there's nothing bad happening, those are kind of the ones that seem naive and maybe not as exposed to the real world of medicine as much. And so that comes through shadowing, that comes through if you work in a hospital, volunteer in a hospital, those sorts of things. So I've seen many students kind of come in with that attitude, and it usually it doesn't bode well in terms of the application. Other things, just not being prepared in terms of not taking not seemingly putting enough time into your application itself, and making sure you take time to do your personal statement, take time to do your all your essays and everything like that, get good letters of recommendation, do all the extracurriculars that you can. Sometimes it just seems like they're, half-heartedly doing it. And so that, kind of prevents people from getting, accepted. If that's kind of the sense and the tone that, comes across on your application, it raises a lot of question marks for the admissions committee. So next question, is there a significant gap of knowledge between CRNA and anesthesiologists? So for an experienced CRNA, I would say no. For, the younger CRNAs, I would say yes, just because they haven't had as much experience. Anesthesiologists go through, medical school, they go through residency, possibly a fellowship. So their training process is so much longer. They see so much more versus, sometimes the CRNAs, they don't have that, experience level. And so, residency is extremely powerful in terms of, getting to see as many cases as you can. And so that'll just prepare you even better for the future. And, you went through medical school as an anesthesiologist, so you kind of have, a very well-rounded, knowledge base in many forms of medicine. And so that also helps a little bit in terms of, how you think about things. Beyond that, there's also kind of the idea that nurses are taught in a different manner for the most part, so they kind of look more to checklists and protocols a lot of times. Where individuals who go through medical school, they typically are independent thinkers, and so they kind of think critically about the situation and can kind of think outside the box. And one thing about anesthesia is you kind of have to be a very critical thinker, and if something's not working, or maybe your equipment isn't the exact one that you want, you need to know how to like change it and make it so that you can use it. So kind of just that outside the box thinking, I think kind of sets us apart as well. Obviously they have board exams just like we do, and so they have to pass their boards, have a certain level of knowledge, and so it I think they're great in certain situations, but when it gets kind of tougher and more sick patients, I would prefer an anesthesiologist. So what does your typical day or shift consist of as an anesthesiologist? It's highly variable, to be honest, and so it really depends on where you're working, what practice setting you're in, everything like that. So a lot of jobs have typical shifts, maybe 7 to 3, 7 to 5, something like that. Other jobs 24 hours, you're on call, those sorts of days happen. So it's pretty variable. As a resident, it's highly variable as well. We're maybe a little bit on the longer side in terms of hours versus once you're an attending anesthesiologist, your hours will go down. But it's pretty variable. What do you do if someone wakes up or starts to wake up mid-surgery? So yeah, you basically just give them more medicine. And so, we call it deepening the anesthetic. So either more inhaled anesthetic, or we give them, IV anesthetics. But basically we give it to, give them more medicine to keep them asleep. It has happened before, and not to the point where they're opening their eyes or anything. Basically we look at their vital signs, and usually they become a little bit more tachycardic, meaning their heart rate goes up, their blood pressure may go up. They may start breathing, and we can detect that on the ventilator, if they're breathing on their own versus if they're just getting their breath from the ventilator itself. And so we can, kind of detect all those things, and then we just give them more medicine. So quickly, because I have to go, how will admissions committees view clinical experience during COVID since it's very limited? Yes, so for the next 2 to 3 years, it's going to be quite limited. They're going to have to just kind of, understand that it's not not as easy as it was previously. So if you don't have as much clinical experience, virtual shadowing, virtual opportunities, all those sorts of things will help. And so try to do as many of the virtual things as you can, in order to, try to get, some sort of, activities on your application. But in terms of actual clinical hours in the hospital, it's going to be limited. And I think the medical schools will just have to accept that. The other thing is you can, or I hope at least that by the end of this year, we'll be able to, get some more, clinical hours in hospitals and get back to more of a normal setting. But it's going to just be hard to predict with the pandemic. So.
Thank you so much, Dr. Janiczek. We really, really appreciate you taking the time to present such awesome cases and answer all of our questions. And we really appreciate your time. For everyone still watching, the Google form has been posted in the chat box, and it will be posted in the video description shortly. And you have 30 minutes from now to fill that out. And once again, thank you so